during our excellent discussion earlier, but this is a similar patient like we saw, L4-5 degenerative listhesis, tall disc, facet cyst, and I think in this patient there are a lot of different options like we've talked about. The keys to success don't change regardless of the type of surgery that's being done. If you're addressing stenosis, you want to get a good decompression. If you're addressing instability, you want to make sure you stabilize it. And if there's deformity, then you want to optimize alignment. And I think when we think about this particular problem, it's been an interest of ours. This is just some of the literature we've published in the last year. When we look at minimally invasive decompression versus TLIF for these types of cases, what's important to understand, as we've heard, is that both of these options are good options, but you have to talk to the patient and think about the specific nuances in order to determine which might be the best option for the particular patient you're dealing with. And then we think about the necessity and risk factors for fusion after decompression alone. What we had found was that if you're less than 70 years old, if you have symptoms of primarily neurogenic claudication, and if you have any significant comorbidities, these all seem to be independent risk factors of needing more surgery. So sometimes these types of guidelines can be helpful. And then with regards to the back pain, leg pain question, I thought this was particularly interesting, where even patients who presented primarily with a complaint of back pain, those patients, their back pain did get better with our surgeries. So I think, we can't, obviously we primarily do these surgeries for leg pain, but I think back pain can get better as well. In terms of what do we want to do to optimize alignment, I think we want to make sure that we can, or optimize outcome, I should say. I think using large screws, I think using intraoperative techniques to reduce radiation exposure, expandable cage technology, all of these things can be helpful. What are we doing in an MI-TLIF? So just a little step-by-step, you want to identify the facet joint, you want to identify Cambin's triangle and the disc space that you're going to work on. Then you want to make sure that you're doing a good prep of the disc space itself, because this is a key to not only getting a good reduction of the listhesis by getting out all of the disc, but also ultimately to optimize fusion. And then if you want to do an over-the-top decompression, as we just saw very nicely, you can add that. I have to say, at this time, I almost never end up doing an over-the-top decompression. A lot of different tools to use when we're thinking about minimally invasive TLIF surgery. And over the last 15 years, I feel like I've kind of done them all. When I started doing minimally invasive TLIF, it was primarily using fluoroscopy and guide wires. This was my operating room about 11 or 12 years ago. The problem with using X-ray is that there's a lot of X-ray. And if there's one thing that you can leave here with this talk, I think the benefit of using intraoperative enabling technology is to get rid of this problem. So if you just say the word X-ray every time the picture changes, you can imagine how many X-rays are being done here. X-ray, X-ray, X-ray. You saw my hands, you see my fellow's hands, so a lot of radiation in these cases, which is a real problem. We had looked at this, and even when I was pretty good at doing these surgeries, we were still using almost 2 minutes of fluoroscopy, and then the outcomes are not perfect. So we started to use this skin-based navigation, and I think with navigation, what's nice is that, you can eliminate the X-ray machine, you can get really good imaging and get sort of more perfectly placed instrumentation. It's easier to work around these like large hypertrophic facet joints, and you can use it for how you want to dock your tube, how you want to insert your inner body cage. But ultimately, if you think about, does it reduce radiation? Like, does using navigation reduce radiation compared to fluoroscopy? And I think this is very important here. You can see the time of surgery doesn't change very much. It added an extra 5 minutes to use the navigation. But if you really look at the radiation dose and the time, we got it down to 26 seconds from those 2 minutes. So using navigation or some type of enabling technology can be very valuable. We also put in better screws. And then I'll just briefly talk about robotics. I think, robotic navigation, I think, is a game changer for many reasons. And what it allows us to do is it allows us to tackle cases like this with very collapsed discs. We want to get a good restoration of height. We want to get good reduction. I think planning the screws, this is what I was talking about earlier, even in the patient with osteoporosis and things, you could really plan big, large, long pedicle screws. I use more 8.5 by 60 millimeter pedicle screws now than I ever have before. And you can see here, for a training tool, here's my fellow, and, we can really watch exactly how the screws are going in. We attach the arm to the robot so that it's very, very stable. When we're doing our facetectomy, you can navigate it when you're putting in your inner body, and also when you're preparing your inner space, having the ability to navigate is very nice. And so you can really get excellent reduction. You can put in these large cages that are expandable, big pedicle screws to help reduce and hold the reduction. And I think, this issue previously, getting a solid fusion using minimally invasive techniques can always be very challenging. Using infuse, like a lot of surgeons do in the United States, can have its own set of complications. So I've started, now published on using iliac crest autograft, and we harvest it through minimally invasive techniques. But that inner body prep is so important, and allows for good outcomes with regards to fusion. So if we break it down into 5 key steps, my steps that I teach our fellows is, do the intraoperative image capture, find the facet joint and take out the facet, prep the inner body, decorticate and fuse the contralateral facet, and then pass your rods. And that all happens after the screws. Thank you very much.